Greetings and a warm welcome to all the dignitaries present here. I'm Sreyashi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most reliable digital platform, offering a multitude of enriching services exclusively for the artists. It is with great pride that Planet serves as the digital partner for this event, and the focus of today's session is Autonomic Nervous System. So let's begin today's session, for which I would like to invite Dr.Meenakshi sir to take over. Sir is a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Penny and Stanley Medical College, Chennai. He is a former national vice president of the Indian Society of Anesthesiologists and has held key positions, including governing council member, president, and state secretary of the ISA Tamil Nadu State Branch. So, without any much delay, now I would like to hand over the session. Over to you.
Thank you, Shreyasi from ClubNet for your opening remarks. I welcome all the faculty and delegates for the 44th webinar of Puthukkottai Bhudhan second edition. I wish to inform all of you that 43rd webinar was conducted under the theme General Anesthesia, and even it was participated by faculty from Bangalore Medical College and Research Institute. Now for 44th also they are participating. In 43rd, the theme was on general anesthesia, and Dr. Shreya SK, postgraduate, talks about vein circuit and modifications, and Dr. Chandrakala C talked about uptake and distribution of inhalational anesthetic agents, and Dr. Sumaya Sabreen talked on Sugamadex, and the moderator was Dr. Raghavendra. All four faculty were smiling from the beginning to the end, and 987 people attended the webinar live. Then YouTube recording also sent to the people. And today I welcome again the Bangalore Medical College people. The youngest postgraduate, that is youngest faculty, is Dr. Shashank Hiremath. So Dr. Shashank is looking like a Bollywood hero. So he has done his MBBS from Ramaya Medical College. Then he is doing his MD in Bangalore Medical College. And in addition to the curricular activities, he is interested in badminton and basketball. So he is good at that. And the main part is most of the times Puthukkottai Bhudhan will act as a free matrimony for the people. And now Dr. Shashank is an eligible bachelor, and a minimum 900 people will be seeing him. And now I repeat, he is a MD anesthesia resident in Bangalore Medical College, and he is good at curricular as well as he is interested in badminton and basketball. So this is a clue I can give to them, and it will be followed by Dr. Bhargavi Sanket. And Dr. Bhargavi has finished her MBBS, and she has obtained DIPNB. Usually, DIPNB is tougher than a regular MD, and she has covered from Fortis Hospital from Bangalore, and she has not stopped with that. She has gone for pediatric anesthesiology fellowship, and she has obtained Indian diploma in regional anesthesia. So I am very happy to say Indian diploma in regional anesthesia, because usually we say American diploma, American board. Now we are very happy to say she is a IDRA candidate, and presently she is a assistant professor in Bangalore Medical College and Research Institute. And madam is having 10 publications to her credit, both national and international magazines she has published. And she's faculty in all the state and national conferences. She has presented paper in national and state conferences also. And currently, she is pursuing a research project funded by Rajiv Gandhi University. She is interested in pediatric anesthesia. And as any other youngster in this present era, she is interested in ultrasound-guided regional anesthesia and airway management. Not with that, she is a classical Carnatic musician. So she is good at singing because we used to sing only in bathrooms. And madam is a trained and a professional classical singer in Carnatic music. And in addition, she is interested in art and craft. So I wish her all the very best, and people should know, even though she has obtained this diploma, DNB degree and other fellowships, she is continuing her interest in the classical music also. That is necessary for us to relax. So that is mandatory for all anesthesiologists, especially for all doctors, because it is the stress reliever. So it should be like that, and it will be followed by Dr. Yatish SK. Again, he is also a dependent holder. So I think Bangalore Medical College can boast they are having so many dependent candidates. So he has done MBBS from Vijayanagara Institute of Medical Sciences and a diploma in anesthesiology from Mysore Medical College and a dependent from Hindurao Hospital, New Delhi. And he has also 10 publications. So both are same, Dipembi and the 10 publications. Then he has 4 international and 6 national publications. Again, he is also interested in ultrasound guided regional anesthesia. I don't know why, what is the similarity between them. And he is interested in simulation anesthesia and pain management. In addition to that, he is having so many hobbies. He is a great sportsman like me, because he's active sportsman where he spends a lot of calories like me, because I am also interested in that sport which requires a lot of calories, that is chess. He's interested. He's playing only chess. That sort of the same enthusiasm. I was also a university player. Twice I represented All India Inter-University in chess. So that is a sports. You can spend a lot of calories, but in addition to that, he is interested in table tennis, trekking also. So because he is playing only chess, if to spend the energies, I think he is interested in trekking. So both of them, these assistant professors are having similar qualifications. I wish them all the very best. And when these DIP-NB candidates are there, then we want a greatest personality to moderate these people, because these people will not obey our orders. We have placed a professor from their medical college so that they will oblige her. So that professor, just to maintain the reputation, Madam is a PhD graduate. Dr. Sandhya is a PhD graduate, and she is not only a professor in Bangalore Medical College, she is in charge in a simulation center. In skill centers and simulation center, Madam is in charge. She's not only with PhD. Now you see, great people will achieve things because they want to go high and higher up. That is the idea. So in spite of her PhD, she has acquired a graduate degree in postgraduate degree in diploma in hospital management and health administration. She has not stopped with that. She has won the TNJA award, Gujarat State Award in 2003. But she is seen as if she was born in only 2003. But she has got that, so that reputation she maintains. And more than that, she has won the Woman Achiever Award by Rotary. So she is not only respected by the medical people, she is respected by the non-medical people also. And she has conducted so many simulation workshops for ISA and ICA and SOAPC. So she is interested in simulation. He has to conduct a simulation workshop, how to be great people like her. So she is interested in simulation anesthesia, pediatric anesthesia. And in addition to all these, she is interested in traveling. And my father used to scold me, why you are roaming here and there every time we are going. Now they are saying technically we are traveling. We are interested in traveling, and she is exploring many places. In food also, she is exploring, and she has seen this assistant professor has published 10 publications, and this assistant professor has published 10. So put together it is 20. So madam wants to excel. So she has 28 publications to her credit. So it is really nice to see a fantastic team from Bangalore Medical College. And now they are going to enlighten us on autonomic nervous system. Now, Dr. Sandhya, madam, it is over to you.
Yes, sir. Sir, thank you so much. We bring greetings from Bangalore Medical College and Research Institute. In fact, heartfelt gratitude for such a kind introduction of all of us, sir. And thank you for giving us an opportunity to speak on this very pertinent topic. I'm sure all the postgraduates are aware that during induction of anesthesia, they always wonder how patients respond to induction, intubation, or it could be spinal anesthesia. It's quite unpredictable how they respond to induction, change of position. But I think they need to understand that the autonomic nervous system is the inbuilt regulator of the whole body. So it is one system that controls a lot of ways by which the patient will respond to all these incidents during anesthesia. So I think we'll have a revisit to the anatomy, physiology of the autonomic nervous system, look at some of the pharmacology and few tests to test its dysfunction, and how they're going to realize how these pre-op tests are going to help us predict how the patient is going to behave intraoperatively and post-operatively. And finally, all this is going to benefit us because it will help us optimize our management and finally patient care. So without wasting much time, I invite our postgraduate, Dr. Shashank, to talk on the anatomy and physiology of the autonomic nervous system. Over to you, Shashank.
Thank you, ma'am. So good evening, everybody. I'm Dr. Shashank Hiremath I'm postgraduate in Department of Anesthesiology in Bangalore Medical College. And I'll be talking about the anatomy and physiology of autonomic nervous system. So anatomically, nervous system can be divided into central nervous system, which consists of the brain and spinal cord, and the peripheral nervous system, which consists of all the other nerves and sensory structures outside of the brain and spinal cord. Peripheral nervous system is again further divided into somatic system, which involves voluntary control of skeletal muscles, and autonomic nervous system, which involves involuntary control of glands and smooth muscle. This is again further divided into sympathetic and parasympathetic system. Sympathetic system is involved in fight or flight response, whereas parasympathetic is involved in rest and digest response. So what is autonomic nervous system? It is a part of the peripheral nervous system as discussed, which controls all involuntary functions. It regulates smooth muscle, cardiac muscle, and glands. It maintains homeostasis and coordinates visceral activities. It works without conscious control, and it has two major divisions, which is sympathetic and parasympathetic, plus another enteric system. So the organization of autonomic system becomes important, where the central control is by hypothalamus, brainstem nuclei, and spinal cord. There are two components in this, which is preganglionic and postganglionic neurons. So the preganglionic neuron will originate in the CNS, whereas the postganglionic neuron will project to the effector organ. So a comparison between the autonomic system and the somatic system. So in the autonomic system, the sensory afferent are the interceptors, which are present in blood vessels and visceral organs, whereas in somatic system, it's the somatic sensory and the special sensory neurons. The motor afferent in autonomic system will be the preganglionic neurons present in the brain and spinal cord, and the postganglionic neurons which are present outside the CNS. And in somatic system, the motor afferent will be the alpha motor neurons. The effector organ in autonomic system will be smooth muscle or glands, and somatic system will be skeletal muscle. So the control on autonomic system, as discussed, is involuntary from hypothalamus, regulatory input from limbic system, brainstem, thalamus, and spinal cord. Whereas for somatic system is under voluntary control, with mainly cerebral cortex being the source of information, with contribution from basal ganglia, cerebellum, brainstem, and spinal cord. So location of ganglia for autonomic nervous system is outside the CNS, whereas in somatic system, the motor area will be in the central nervous system, whereas sensory ganglia will be in the dorsal root ganglia of the spinal cord. Neurotransmitters, preganglionic will be acetylcholine in both systems, whereas postganglionic for parasympathetic is acetylcholine, whereas for sympathetic is norepinephrine. For somatic system, neurotransmitter is always acetylcholine. So what is sympathetic nervous system? So basically the outflow originates from the intermediolateral cell column of the thoracolumbar spinal cord segments T1 to L2. Preganglionic neurons in this region will send myelinated B fibers through the ventral roots into the white rami communicants. So these fibers will then enter the paravertebral sympathetic chain, which will extend from the cervical region till the sacrum on either side of the vertebral column. So within this chain, there are three possibilities. Either they can synapse at the same level within a paravertebral ganglion. They can ascend or descend the chain to synapse at a different level, maybe cervical, thoracic, or lumbar ganglia. or they can pass through the chain without synapsing and continue as either splanchnic nerves to reach the prevertebral ganglia such as celiac, superior mesenteric, and inferior mesenteric. So these sympathetic fibers supplying the head and neck will ascend to the superior cervical ganglion, from which the postganglionic fibers will reach the eyes, salivary glands, and facial skin. There is cardiopulmonary sympathetic fibers arising from T1 to T5, which will form the cardiac and pulmonary plexuses. And abdominal and pelvic organs will receive the input via lumbar and sacral splanchnic nerves. So parasympathetic nervous system, which is the opposite of sympathetic nervous system, this will constitute the craniosacral division of the autonomic nervous system. So the outflow will be from cranial nerve nuclei 3, 7, 9, and 10, which is in the brainstem, and the sacral spinal segments S2 to S4 in the spinal cord. The neurotransmitter for this system at both preganglionic and postganglionic will be acetylcholine. So this system is purely cholinergic. So as discussed, there is cranial outflow. The four nerves involved will be first oculomotor nerve, which originates in the Edinger-Westphal nucleus, and through the ciliary ganglion, it will supply the sphincter pupillae and the ciliary muscle. Facial nerve nucleus originates from superior salivatory nucleus, and through pterygopalatine and submandibular ganglia, it supplies lacrimal, submandibular, and sublingual glands. The glossopharyngeal nerve originates from inferior salivatory nucleus, and through otic ganglion will supply the parotid gland. The vagus nerve originates in dorsal motor nucleus and supplies the thoracic and abdominal viscera up to proximal 2/3 of the colon. Neurotransmission. So in this entire system, there is information which is being passed on, and there are certain neurotransmitters which are in use. So for the sympathetic system, preganglionic is always acetylcholine, which will act on nicotinic receptors, and postganglionic is norepinephrine, which will act on alpha and beta receptors. Adrenal medulla is a modified sympathetic ganglion, which releases 80% of epinephrine and 20% of norepinephrine. In the parasympathetic system, both pre and postganglionic neurons will secrete only one neurotransmitter, which is acetylcholine. The receptors are again two, nicotinic and muscarinic. Nicotinic are present in the ganglionic synapse, whereas muscarinic receptors are present in the effector organs. The other neurotransmitters used are dopamine, ATP, neuropeptide Y, vasoactive intestinal peptide, and nitric oxide. So coming to acetylcholine, which is a major neurotransmitter both in somatic and autonomic nervous system. So synthesis is by the combination of choline and acetyl-CoA via choline-acetyl transferase, which leads to acetylcholine. It is released by calcium-dependent exocytosis at the synaptic terminal. So we can see that only when in the short video next to the text, we can see that only when the calcium enters the preganglionic neuron, that is when the synaptic vesicle will release the neurotransmitter. It is terminated by hydrolysis by acetylcholine esterase, acts on two receptors as discussed, nicotinic receptors, which are ligand-gated ion channels, and muscarinic receptors, which are G-protein coupled receptors. So the anesthetic implication here is when we use anticholinesterase during reversal like neostigmine, this will reverse the neuromuscular blockade by increasing acetylcholine at the neuromuscular junction. Norepinephrine synthesis. So norepinephrine is derived from amino acid tyrosine, which on further metabolism will give DOPA, which gives rise to dopamine, norepinephrine, and epinephrine. And all of this synthesis takes place within the adrenal medulla. It is stored in synaptic vesicles of postganglionic sympathetic neurons. It is terminated by either reuptake, diffusion, or by MAO or COMT degradation. So the implication here is when the patient is on MAO inhibitors, and we'll give indirect sympathomimetics during our anesthetic management, there can be an exaggerated pressor response. The other co-transmitters like dopamine is an intermediate in norepinephrine synthesis. It acts on D1 to D5 receptors, mainly involved in renal vasodilation. ATP and neuropeptide Y is also co-released with norepinephrine, which leads to prolonged effects of this neurotransmitter. Vasoactive intestinal peptide and nitric oxide are parasympathetic co-transmitters used for smooth muscle relaxation. So clinically, dopamine infusions when used for renal perfusion in excess can lead to tachyarrhythmias. Coming to adrenergic receptors, broad classification is alpha and beta receptors. Majorly used will be alpha 1, alpha 2, beta 1, and beta 2. So alpha 1 receptors are present in the vascular smooth muscle, and they'll cause vasoconstriction, which leads to an increase in blood pressure. Alpha-2 receptors are present in presynaptic neurons in the central nervous system, which leads to decrease in norepinephrine release. Beta-1 receptors are present in the heart, which increases heart rate and contractility. Beta-2 receptors are present in the bronchi and vessels, leading to bronchodilation and vasodilation. Beta-3 receptors are also present in the adipose tissue. Stimulation will cause lipolysis. And all of these receptors are G protein coupled receptors. Coming to cholinergic receptors, again broadly two classifications, nicotinic and muscarinic. Nicotinic is again divided into two N receptors which are present in autonomic ganglia involved in synaptic potential transmission. NM receptors present in neuromuscular junction used in skeletal contraction. M1 muscarinic receptors is present in the central nervous system and in gastric glands and used in increased secretion of the gastric glandular secretions. M2 receptors are present in the heart, which decrease heart rate and contractility. M3 receptors are present in smooth muscle and other glands, which give response in contraction and secretion. So autonomic reflexes is a major part in this autonomic system, which also plays a vital role in our anesthetic management. So we'll find out what it is. So autonomic reflexes are involuntary subconscious responses mediated by the autonomic nervous system to maintain homeostasis in response to external or internal stimuli. So these reflexes have a visceral efferent input, central integration either in spinal cord, brainstem, or hypothalamus, and an autonomic efferent output to smooth muscle, cardiac muscle, or glands. Autonomic reflexes are polysynaptic and are modulated by higher centers as discussed before, like hypothalamus, reticular formation, and limbic system. So what does a reflex have? It typically consists of a reflex arc, which first has a receptor in the viscera or the vascular wall, which will detect any change such as stretch, pressure, and chemical composition. And then the afferent neuron will carry this impulse to the central integration center, often via cranial nerves, glossopharyngeal nerve, vagus nerve, or a spinal visceral afferent. Then we have an interneuron network in the spinal cord or medulla, which will process this input, and an efferent pathway to sympathetic or parasympathetic nerves, which will modulate the effector organ activity. So we shall discuss all these reflexes one by one. So baroreceptor reflex, the stimulus will be a stretch in the carotid sinus or the aortic arch carried by the glossopharyngeal and vagus nerve. This will cause an alteration in the heart rate and vascular tone depending on the stimulation. So parasympathetic will cause a decrease in heart rate and contractility. Sympathetic will cause an increase in heart rate and contractility. So the anesthetic relevance is that this will be blunted by volatile anesthetics and the opioids, which will cause a risk of hypotension. Next is the chemoreceptor reflex, where the stimulus is hypoxia and hypercapnia detected by the carotid and the aortic bodies. The response will be an increase in ventilation and sympathetic tone. The relevance is that this will be depressed again by the general anesthesia and opioids. Oculocardiac reflex, the stimulus is traction on the extraocular muscles, which is carried by trigeminal nerve and then passes on to the vagus nerve, leading to bradycardia and arrhythmia. So this is very common in ophthalmic surgeries, and this can be prevented by anticholinergics. Celiac reflex, where the stimulus is peritoneal traction or mesenteric traction, which will lead to bradycardia and hypotension. This is obviously seen in abdominal surgeries and laparotomies and can be treated with atropine or a deeper plane of anesthesia. The Basal-Gyrus reflex, where the stimulus is a ventricular stretch either due to ischemia or hypovolemia, which will again lead to bradycardia and vasodilation. And this can cause severe hypotension during spinal anesthesia. Krashmer's reflex, where the stimulus is nasal mucosa irritation carried by trigeminal nerve, and then the efferent will be the vagus nerve. This leads to apnea, bradycardia, and hypotension. So this can be triggered during airway suctioning, nasal instrumentation, nasal packing. So we need to be aware of this reflex. Now, what will these systems broadly do to all the organs? So in the heart, sympathetic will cause an increase in heart rate and contractility, whereas parasympathetic will decrease it. In lungs, here there's bronchodilation, there's bronchoconstriction. GIT, there's decreased motility in sympathetic stimulation, whereas increase in parasympathetic. In the eyes, here there's mydriasis and there's meiosis. In the bladder, sympathetic stimulation will cause relaxation, whereas parasympathetic will cause contraction of the detrusor muscle. Liver will cause, sympathetic system will cause glycogenolysis, whereas parasympathetic will lead to glycogenesis. And in skin, sympathetic stimulation will cause increase in sweat excretion. So, very short note on enteric nervous system, which is also included in the autonomic nervous system, but can't clearly be classified into sympathetic or parasympathetic. So basically, this is a network of neurons and their supporting cells found within the walls of the gastrointestinal tract, pancreas, and gallbladder. These are of neural crest origin, which will migrate along the vagus to the gastrointestinal tract. There's an extreme degree of local autonomy, but sometimes it is influenced by sympathetic and parasympathetic nervous systems. So these are mainly divided into two plexuses, the myenteric or the Auerbach plexus, present in the external longitudinal and inner circular muscle layer, and the Meissner's plexus, present in the submucosal plexus. Thank you.
Thank you, Dr. Shashank, for that crisp and informative talk on the anatomy and physiology of the autonomic nervous system. And now we have Dr. Bhargavi Sanket presenting the pharmacology and a few tests to test the integrity of the autonomic nervous system. Over to you, Dr. Bhargavi.
Thank you, ma'am. Good evening, everyone. I'm Dr. Bhargavi Sanket. Greetings from Bangalore Medical College and Research Institute. At the outset, I would like to thank the team of Puthukkottai Bhudhan for giving me this opportunity. So, the work of the autonomic nervous system can be compared to an anesthesiologist because it is always present behind the scene and they orchestrate the amalgamation of the functions of the various organ systems. It never stops functioning, it never sleeps, it never shifts gears. Like we have already seen, the parasympathetic nervous system coordinates the rest and digest phases of the body, and during the fight and flight response, the sympathetic system becomes active. We've already seen how this functions with the anatomy and physiology. So I will be going directly with the pharmacology, and later we will be looking at few tests to evaluate the functioning of the autonomic nervous system. So the major classes of the drugs are the adrenergic and the cholinergic drugs. So drugs which amplify the action of the sympathetic nervous system are the sympathomimetics or the adrenergic agonists, and the drugs which negate the action of the sympathetic system are the adrenergic antagonists or the sympatholytics. So similarly, the cholinergic agonists amplify the action of the parasympathetic system, and the cholinergic antagonists negate the action of the parasympathetic system. So coming to the adrenergic agonists, they are divided into three types depending on the mechanism of action. First is the directly acting agonist, which may be selective and act on only one receptor like alpha-1 phenylephrine, alpha-2 receptor clonidine and dexmedetomidine, and beta-1 receptor dobutamine, or they may be non-selective and act on a series of alpha and beta receptors. Along with this, mixed acting and indirectly acting, we will be dealing only with the direct acting adrenergic agonists. So again, summarizing the action, direct acting sympathomimetics directly act on the postsynaptic receptors and mimic the action of the catecholamines. Indirect acting sympathomimetics act presynaptically, causing increased release of the catecholamines, potentiating their action. And mixed sympathomimetics act on both the presynaptic as well as the postsynaptic sites. So I will be dealing with each of these drugs, and only the pharmacodynamic aspects of the drugs will be covered because the pharmacokinetics can easily be studied in any of the textbooks. By studying the pharmacodynamics, we can understand how each drug functions at the molecular level, and depending upon that, what is their specific use in anesthesia, and also how to predict their adverse effects. So coming first to epinephrine, which is a natural catecholamine, at lower doses of 1 to 2 mics per minute, it acts mainly at the beta-2 receptors, which as we have seen present in the bronchi, causing bronchodilation. Hence, it is used in the treatment of bronchial asthma, severe croup, and also airway edema. And it also acts at the beta-2 receptors, which is present in the skeletal smooth muscles, blood vessels, which cause vasodilatation. Because of this, it causes a modest decrease in the diastolic blood pressure. Metabolic effects include the hyperglycemic response during glycogenolysis and gluconeogenesis. At higher doses of 2 to 10 micrograms per minute, epinephrine acts on the beta-1 receptors, which is predominantly present in the heart, having a positive inotropic, chronotropic, and the dronotropic effect. So there's an increase in the heart rate, blood pressure, and cardiac output. This is why it is popularly used in the situations of cardiac arrest. It also causes release of renin from the JG cells of the kidney, and this helps in maintaining the renal blood flow and the urine output. At higher doses, that is more than 10 micrograms per minute, it has selective action on the alpha-1 receptors, which are present in the blood vessels, causing vasoconstriction and rise mainly in the systolic blood pressure. Because of this action, it is popularly used in the treatment of hypotension, and 1 mg bolus is what we have all studied in the ACLS-BLS guidelines to be used in cardiac arrest. Anaphylaxis, it can also be combined with local anesthetics because it causes a vasoconstrictive effect. It decreases the systemic absorption of the local anesthetic, prolonging their action. It is also used in dilute solutions of local anesthetic in tumescent anesthesia because it causes vasoconstriction of the blood vessels, limiting the blood loss. So, depending on these actions, few unique points about epinephrine is that halothane sensitizes the heart to the action of these catecholamines. Hence, when we are using epinephrine, like in tumescent anesthesia for liposuction, halothane must be avoided. Because it causes increase in the heart rate, it shortens the refractory period and accelerates the phase 4 depolarization. There is increased risk of development of arrhythmias. Reflex bradycardia, though I have mentioned it, it may not be a possibility because even the systolic pressure rises, the diastolic pressure falls because of the relative vasodilatation of the skeletal muscle blood vessels. Hence, routinely it may not be seen, but in higher doses it may be seen. Next, coming to norepinephrine. Norepinephrine has similar actions to epinephrine, only that it does not have any beta-2 action. At low doses of less than 2 micrograms per minute, it has beta-1 action and hence it's used in cardiac arrest, also causes renin release. And at higher doses, it has alpha-1 action. And here, there is rise of both systolic and diastolic blood pressure because of lack of skeletal muscle blood vessel dilatation. This can cause a sudden increase in both systolic and diastolic blood pressure. And because of this major alpha-1 action, it has been widely used for circulatory collapse. It may be in septic shock, anaphylaxis, etc. This is seen when the doses increase more than 3 micrograms per minute. Because of this sudden increase, there is a baroreceptor mediated reflex bradycardia, again arrhythmias, and because it causes vasoconstriction of all the vasculature, even the splanchnic and splenic capsule, there is chances of renal failure because of decreased renal blood flow, mesenteric infarctions, and because of low hepatic blood flow, it can delay the hepatic drug metabolism. Norepinephrine has a short half-life and hence it must be always given in infusion form. Next catecholamine is the dopamine, which has primarily a DA1 action at doses of 0.5 to 2 micrograms per kg per minute, which is present presynaptically at the renal, mesenteric, and the splenic blood vessels. So the major action is vasodilatation, helps maintaining the renal blood flow and the splanchnic blood flow. Hence, it is used popularly along with noradrenaline to maintain the renal blood flow and urine output. At higher doses of 2 to 10 micrograms per kg per minute, it has a specific beta-1 action and hence it is used in circulatory collapse. In doses above 5 micrograms per kg per minute, it also helps in the release of endogenous epinephrine. In higher doses of 10 to 15 micrograms per kg per minute, it's mainly an alpha-1 action leading to vasoconstriction and helps used in circulatory collapse. So the adverse effect include again tachycardia, arrhythmias, myocardial infarction, and attenuation of the ventilatory response to hypoxia has been observed with dopamine. This also has a short half-life and hence must be given in infusion form. Dobutamine and isoprotenolol have selective beta action. They do not have alpha action. Isoprotenolol is more potent as compared to dobutamine. And first is the action on the beta-1 receptors. So better contractility is seen with isoprotenolol as compared to dobutamine. And because of the beta-1 action, they are used in chronic cardiac output, low cardiac output states, MI, bradyarrhythmias, especially during the placement of a pacemaker, so that the heart rate can be maintained till the pacemaker has been placed. At doses of higher doses, they have a beta-2 action, which is a beneficial bronchodilation and skeletal smooth muscle dilatation and hyperglycemic response. The doses of isopretilin is less as compared to dobutamine. Tolerance is seen with both of these drugs on prolonged infusion, and hence to prevent this tolerance, it can be given in intermittent doses, or there can be change in the concentration of these infusions. So a small question for the postgraduates: what is the ideal vehicle for the infusion of these catecholamines? Whether it is normal saline or was it 5% glucose, and what is the cause? The next drug which we will be discussing is salbutamol, which has a selective beta-2 action causing bronchodilation, and hence situation of use is bronchial asthma. It also causes skeletal muscle blood vessel vasodilatation, and hence this can cause tremors, restlessness, and nervousness. It also elicits a hyperglycemic response. It can be used in the dose of 0.25 to 0.5 mg, either IM or subcutaneous, or in the inhalational route 100 to 200 micrograms. It has a more selective beta-2 action as compared to the beta-1 action, and hence there is lesser complications of tachycardia and arrhythmias. Next, coming to phenylephrine, it has a selective alpha-1 action causing vasoconstriction, more specific action on the veins as compared to the arteries, leading to rise of the blood pressure, both the systolic and diastolic blood pressure. Hence, it is used in the treatment of hypotension, especially fall in pressure secondary to subarachnoid block in the cesarean sections, labor epidural analgesia, and also septic shock, anaphylaxis, etc. It can be used even as a nasal decongestant when we are attempting nasal intubations. It is used in the dose of 0.1 to 1.5 micrograms per kg per minute. It can cause systolic bradycardia because of baroreceptor mediated sudden increase in systolic and diastolic blood pressure, and it can cause hypertension on prolonged use. Clonidine has a specific alpha-1 action, and alpha-2 action is more than the alpha-1 action in the ratio of 200:1. Alpha-2 action mainly on the central receptors inhibits the entire sympathetic outflow to the body, and it also acts peripherally at the prejunctional receptors, inhibiting norepinephrine release. Because of this action, it produces a sedative effect which is similar to the normal sleep. Hence, it has been popularly used as a pre-medication to decrease the requirement of the general anesthetic drugs, and also in post-operative sedation, ICU sedation, NORA, etc. It also has analgesic effect because of the central desensitization, and can be used epidurally in the doses of 75 to 150 micrograms, and also spinal 15 to 30 micrograms. It can be also used IV at 1 to 2 micrograms per kg per minute loading dose of up to 10 minutes, and 0.2 to 0.7 micrograms per kg per minute of infusion. It helps in maintaining hemodynamic stability, avoiding the hypertensive response to surgery, intubations, etc. It can lead to adverse effects associated with this include I'm sorry, the slides are not changing.
See if you can escape once and get back.
Yes, ma'am.
Madam, it is now changing.
Yes, it's gone to the next slide.
It's okay.
Okay. Okay. Okay, the adverse effects include bradycardia because of the sudden alpha-1 action, and also hypertension, and also it can cause sudden withdrawal, it can cause rebound hypertension and tachycardia. Dexmedetomidine has a similar action to clonidine, but it has a more specific alpha-2 action of 1600:1. Rest of the profile is similar to clonidine. It can be used in the doses of 1 microgram per kg loading dose, followed by 0.2 to 1.4 micrograms per kg per hour infusion, and epidural 1 microgram per kg. Adverse effects remain the same. Next, coming to the adrenergic antagonists, we have specific alpha receptor antagonists, which may be non-selective, like phenoxybenzamine and phentolamine, alpha-1 selective or alpha-2 selective. But because we are not dealing with these drugs routinely, I'll not be discussing of any of these drugs. Beta receptor antagonists include non-selective or the first generation drugs like propranolol, which act on both beta 1 and the beta 2 receptors, or beta 1 selective antagonists, that is esmolol and metoprolol, and the third generation drugs which have an additional vasodilating action either because of release of nitric oxide or endothelial derived relaxing factor or action on the alpha 1 antagonist. I'll be dealing here with labetalol. So first, coming to propranolol, it has beta 1 and beta 2 action. Action on the beta 1 receptors has a negative inotropic, chronotropic and dronotropic effect, and hence it is popularly used in the treatment of hypertension and tachycardia, for a stress response to laryngoscopy, and also other hypertensive patients in the treatment of arrhythmias, and also it's popularly used for the perioperative beta blockade in patients with coronary artery disease, LVH, and in high-risk surgeries to negate the sympathetic effect on the damaged myocardium. It helps preserving the myocardial oxygen supply-demand ratio. But the adverse effect of propranolol is because of its beta 2 action. It causes bronchoconstriction, and along with that, it causes hypoglycemia because of inhibition of glycogenolysis and gluconeogenesis. The additional adverse effect is that there is absence of the sympathetic response to hypoglycemia because of the beta 1 blockade. It can be used in doses of 1 to 3 mg boluses repeated every 5 minutes up to 10 mg. Adverse effects include hypotension, bradycardia, bronchospasm, and as I mentioned, MAST, hypoglycemia, hyperkalemia, and contraindications because of these adverse effects are presence of heart block, cardiac failure, and bronchial asthma. So another question to the postgraduates: overdose of propranolol can present as cardiogenic shock with bradycardia, hypertension, low cardiac output stays, similar to how you seen in cardiogenic shock. So what is the specific antidote for the treatment of propranolol overdosage? Next, coming to esmolol, it is a selective beta 1 antagonist, act mainly on the heart, leading to fall in the heart rate, contractility, and conduction through the AV node. It also inhibits the release of renin through the JG cells of the kidney. Hence, it is used in the acute control of heart rate and high blood pressure, and similarly used in treatment of dysarrhythmias, and the perioperative beta blockade is used in the treatment of coronary artery disease, like how we have already seen with propranolol. It has an ultra short duration of action, and hence it should be given in the infusion form, and a dose of 0.5 to 1 mg per kg loading dose over 1 minute, followed by 500 to 200 micrograms per kg per minute infusion. Adverse effects include bradycardia, hypotension, and AV block, and hence it is contraindicated in the cases of severe bradycardia, heart blocks, and heart failure and shock. Differences between esmolol and metoprolol, though the mechanism action is the same, the only difference is in the pharmacokinetics. Esmolol is an ultra short acting with an onset of action of within 1 to 2 minutes and duration of action of just 10 to 20 minutes because of rapid hydrolysis by the RBC esterases, and it helps in the short-term control of hypertension, tachycardia like laryngoscopy, supraventricular tachycardia, etc. But metoprolol has a slower onset of action of 5 to 10 minutes and a prolonged duration of action of up to 3 to 6 hours and hepatic metabolism. Hence, it can be used for the prolonged perioperative control of hypertension and tachycardia. Next, coming to labetalol, along with the beta 1 antagonist action, it also has action on the alpha 1 receptors. It causes vasodilatation, leading to fall in the systolic and diastolic blood pressure. Hence, it's used in hypertensive emergencies, and the specific use is for the treatment of when you suddenly withdraw the use of clonidine and dexmedetomidine, the effects that are seen can be overcome by the use of labetalol, and also in the acute control of tachycardia and hypertension. It is used in the doses of 5 to 20 mg every 10 minutes till the required effect is achieved, followed by an infusion of 0.5 to 2 mg per minute till effect is received. It does not associate with reflex tachycardia because of the simultaneous beta 1 antagonist action. Contraindications are again asthma because of the risk of beta 2 antagonist action leading to bronchoconstriction, and hence it's also not used in COPD patients. It can also cause heart blocks and cardiogenic shock. So next, moving on to the cholinergic agonists, they can be direct acting that acts on the acetylcholine receptors, or indirect acting, that is they irreversibly bind to the anticholinesterases. Here the reversible drug which we will be discussing is neostigmine, and irreversible is the organophosphorus compounds which we have seen in our ICUs, OP compound poisonings. So neostigmine has major action at the neuromuscular junction. As we have already seen in the physiology, it binds to the anticholinesterases and increase the acetylcholine receptor concentration at the neuromuscular end plate, causing reversal of the neuromuscular block. The adverse effects are all because of the action of the muscarinic receptors, that is M1 to M5, leading to fall in the heart rate, decreased contractility and conduction through the AV node, bronchoconstriction with increased secretions, increased GI motility and increased secretions, and the genitourinary tract, it causes retention of urine, and also it causes meiosis and increased lacrimation. So it is used in the dose of 0.05 to 0.07 mg per kg. As it is lipid insoluble, it has minimal CNS action as it doesn't cross the blood-brain barrier. Anticholinergic drugs can again be natural alkaloids like atropine or synthetic drugs like glycopyrrolate. So atropine mainly acts at the muscarinic receptors M1 to M5 and causes increase in the heart rate, hence is the drug of choice in the ACLS guidelines for the treatment of bradycardia. It has effect on the other systems, decreasing the secretions, decreasing the motility, decreasing lacrimation, and hence it is popularly used as a pre-anesthetic medication in the doses of 0.01 to 0.02 mg per kg. The differences in the atropine and glycopyrrolate is because of its, again, pharmacokinetic profile. Glycopyrrolate has minimal lipid solubility, hence it has no CNS action, and also it has minimal effect on the heart, that is tachycardic response is minimal. It is preferably used with neostigmine because of the minimal CNS and CVS action, and also as a pre-medication as an anti-secretory agent. So coming to the signs and symptoms of autonomic neuropathy. These are very important to pick up specific signs and symptoms to decide which is the organ system involved and at what level is the region, whether it is presynaptic, postsynaptic, preganglionic, postganglionic, etc. So on the heart, the predominant response is the cholinergic response. And hence, when there is autonomic neuropathy, this cholinergic effect is reduced, having a more pronounced adrenergic response. Hence, there is a fixed heart rate, resting tachycardia, development of arrhythmias. Chronotropic incompetence is that the maximum heart rate achieved with exercise is less than 85% of the age reflected values. And also painless ischemia because of abnormal afferent action. Next, the force of contraction is also reduced, leading to exercise intolerance. Coming to blood vessels, the only action is the adrenergic action, and hence absence of this vasoconstriction, both arterial and the veins, leads to dilatation and collection of the blood in the dependent organs, leading to orthostatic hypotension, dependent edema, and cold feet. Next, contraction of the splenic capsule and the splanchnic vascular bed is lost, leading to again hypotension and syncope because of decreased in the CNS blood flow. Next, coming to the bladder, the action on the detrusor muscle is lost, leading to relaxation of the bladder, leading to an atonic bladder, urine retention, and this can act as a site of infections. On the eye, there are both adrenergic and cholinergic actions. Depending upon the lesion involved, we can decide whether it is a sympathetic or the parasympathetic involvement. For example, if there is sympathetic involvement like the Horner syndrome, they present with decreased pupil size, that is meiosis, ptosis, and anhydrosis. If there is a cholinergic involvement such as Adie's pupil, there is presence of mydriatic pupil along with absent light reflexes and slow response to convergence. The action on the sweat glands and salivary glands is mainly the cholinergic action, and hence absence of this leads to anhydrosis, gustatory sweating, and night sweats. The parasympathetic action maintains the GI motility with relaxation of the sphincters. So absence of this action leads to gastroparesis, early satiety because of absence of motility, leading to nausea, vomiting, and dysphagia, constipation, and nocturnal diarrhea. So that we have to follow up the signs and symptoms depending upon the organ system involved with the specific tests for autonomic neuropathy to detect the presence, whether it is present or not what is the distribution of autonomic neuropathy, and what is the severity. The three major set of tests are the sympathetic postganglionic pseudomotor tests, and on the cardiac, the sympathetic and the parasympathetic tests. So before starting the test, the patients have to be advised to have their breakfast or lunch and then report for the testing after 2 hours of having food. Avoid all stimulants like coffee, tea, alcohol up to 24 hours before testing. Avoid any autonomic medication, even antidepressants, antihistaminics, diuretics, other sympathomimetics, the cardiac drugs, etc. at least 2 days prior to testing by taking the physician advice. Then wear comfortable and loose clothing and follow up with the tests. So again, a PG-oriented question. Who was the first who introduced the battery of cardiac autonomic tests, especially used to detect autonomic neuropathy that is observed even today? So coming first to the cardiac autonomic test, we have tests for the parasympathetic system where we check for the heart rate response to either Valsalva maneuver, standing and deep breathing, and then test for the sympathetic system which we observe the blood pressure response to standing, sustained hand grip, and also cold pressor test. These tests can be done by connecting to the routine monitors like how we have in the operation theaters and then taking the readings of heart rate, blood pressure, temperature, etc. Or use power spectral analysis where a specific biomedical variant is studied for variation using the Fourier analysis. Or we can also use the photoplethysmography. This is similar to the technology which you have in smart watches, which can record the heart rate, BP, RR interval, temperature, sweating, etc. And then these data is collected and observed with algorithms. So with an abnormal test, depending on the number of abnormal tests, we can decide whether it's early dysfunction, where there is a 1 abnormal or 2 borderline heart rate tests, or a definitive dysfunction, that is 2 abnormal heart rate tests, or a severe dysfunction where there are abnormal blood pressure tests. So first is the heart rate response to Valsalva maneuver. So the patient is asked to sit down comfortably, connected to routine monitors, baseline readings taken. Then the patient is instructed to take a deep breath and hold it, and against a closed mouth and nose, the patient is asked to push against a forced epiglottis or into a manometer to maintain a pressures of up to 40 mmHg for 15 to 20 seconds. And then the patient is asked to exhale. So what is the physiological effect of this? During phase 1, there is an increase in the intrathoracic pressure, which pushes out the entire thoracic blood volume into the peripheries, leading to a increased LV output, increased blood pressure, and hence a baroreceptor mediated fall in the heart rate. This is phase 1. In the phase 2, there is, because of the continued pressure on the epiglottis, there is decreased venous return, which again leads to a fall in the BP and a rise in the heart rate. In the phase 3, where there is sudden release of the intrathoracic pressure, there is increased venous return mainly to the right side of the heart and not the left side, and hence there is temporary fall in the blood pressure and the increase in the heart rate. In phase 4, that is a normalizing phase where all these changes get normalized. So taking these observations, the Valsalva ratio is calculated. That is the RR interval, which is maximum, which is seen after the release of the pressure, and RR interval minimum, that is during the bradycardic response, that is seen during the holding of the intrathoracic pressure. So the ratio should be a normal of 1.2 is to 2.1, and less than 1.2 is considered to be abnormal. Next is the heart rate response to standing. Here again, the patient is made to lie down supine, connected to the routine monitors, baseline readings taken, and then the patient is made to move from supine to standing. So what is a normal physiology? When the patient stands up, there will be an immediate pooling of the blood volume in the lower body, leading to increased fall in the cardiac output blood pressure. This activates the baroreceptors, that is the vasomotor center in the leading to an increase in the sympathetic tone, leading to increased heart rate, stroke volume, and the cardiac output, which helps normalize the blood pressure. There's also activation in the renin-angiotensin aldosterone system, leading to rise of the peripheral vascular resistance. So here you can see immediately after the patient stands, there is a peak in the heart rate, which is corresponds to a decreased RR interval, and which is maximally seen around the 15th heartbeat after the patient stands. Next, this is a new normalized heart rate is reached by up to the 30th heartbeat, which corresponds to a rise in the RR interval or the relative bradycardia. So this ratio of the heart rate at the 30th heartbeat, and the 15th heartbeat is taken, or a ratio of the longest RR interval divided by the shortest RR interval is taken, which normally should be more than 1.04. Here you can see the abnormal response on power spectrum analysis, where the patients lacks any autonomic heart rate response to standing. Here you can see there is absolutely no response as compared to the normal patients. It is a fixed heart rate. Next is the table tilt test, where the patient cannot stand up. So the patient can be made to lie down on the table tilt, a baseline reading taken, then a 90-degree head up is given, and the heart rate is recorded for every 5 minutes. After 5 minutes, patient is put back to supine position, heart rate and BP recorded again every minute for 2 minutes. So normally you should see a heart rate rise by 10 to 15 beats per minute, or a diastolic rise by 10 mmHg. The third is the heart rate response to deep breathing. So patient is asked to sit down, connected to routine monitors, baseline readings taken, and patient is asked to take 6 deep breaths in 1 minute. So with a deep breath, there is stimulation of the lung stretch receptors, which decreases the vagal firing, leading to a decreased parasympathetic tone and a rise in the heart rate. On expiration, there is fall of the lung stretch, so an increased vagal stimulus leading to an increased parasympathetic activity and a fall in the heart rate. So the maximum heart rate is subtracted with the minimum heart rate. Normally, there should be a difference of more than 15 beats per minute, whereas abnormally you see less than heart rate 10 beats per minute. So here you can see on the left side, the normal patient showing variation in the heart rate, whereas a patient with autonomic neuropathy, there is no changes in the breathing cycle of the patient. Next, blood pressure response to standing. We have already seen the physiology of this with the heart rate response. So patient is made to move from supine to standing, and the systolic blood pressure is measured. So normally there should be a systolic blood pressure fall of less than 10 mmHg and diastolic rises to more than 10 mmHg. Abnormally, the systolic blood pressure falls to more than 20 mmHg and the diastolic falls more than 10 mmHg. Next is the blood pressure response to hand grip. So any sympathetic stimulation causes rise of the sympathetic stimulation into rise of heart rate and the systolic blood pressure. So patient is asked to maintain a hand grip of 30% of the maximum hand grip for 5 minutes, and then the diastolic blood pressure is recorded, and after the pressure is released, the diastolic blood pressure again is recorded. So normally there should be a diastolic pressure increase of more than 16 mmHg. Abnormally in autonomic neuropathy, we see a rise of less than 10 mmHg. So this is in comparison, in gist, all the cardiac autonomic tests. What are the normal values? What is the abnormal values? And what are the borderline values? Tests for parasympathetic as well as the sympathetic function. A cold pressor test is similar to a hand grip test. This is another stimulus for the sympathetic nervous system, where again a heart rate basal recordings are taken and one limb is submerged in cold water and heart rate and BP is recorded. So you can see normal individuals show a systolic pressure increase on placement in the cold water, and which recovers after the stimulus is removed. So this is all about the cardiac test. Now coming to the gastrointestinal tract involvement. So first, to rule out other causes, a gastroduodenoscopy must be done to rule out any mechanical obstruction. Use of manometers to maintain the, to check the pressures at the antrum and also look for pylorospasm. And also for the lower gastrointestinal tract, look for the sphincter tone at the anal level. A double isotope scintigraphy can be used to study the transit time of food inside the bowels, both the small intestine as the long intestine, measuring the colonic segment transit time. Rule out other causes of diarrhea if the patient presents with nocturnal diarrhea by doing a stool examination. Rule out malabsorptive syndromes, celiac disease and steatorrhea. Next, the genitourinary function. A baseline renal function must be recorded along with urine analysis. Ultrasound to measure what is the post-void residual volume, and also a cystogram to measure the bladder sensation, what is the volume pressure with bladder filling. The pseudomotor function is another important tests of the autonomic system. So first you have the QSART, or the pseudomotor axon reflex test. Here the monitors are connected to the forearm and 3 connected to the lower limb, where a stimulus is given like acetylcholine for increasing the sweat production, and the waveform of this sweat production is recorded and compared to the baseline values. It helps to evaluate the post-ganglionic pseudomotor function. Next is the sweat imprint test, where again electrical impulses or acetylcholine is given to increase the sweat secretion, and the sweat is collected in a plastic imprint. So with this, we can note what is the histogram of the sweat, what is the concentration of the sweat glands in that square unit volume, and also volume of the sweat produced in that square area. And next we have the thermoregulatory sweat test, where in controlled conditions patient is warmed up to 38 degrees centigrade and dusted with indicator powder which changes color on sweating, and then the digital photos are taken. So here you can see normal and the abnormal sweating responses in a patient with multisystem atrophy. So this test combined with the QSART test can help in determining what is the site of the lesion. Next, the sympathetic skin response, where again the sweat glands are activated and the skin potential is recorded. A pseudoscan is where the electrochemical skin conductance is measured by reverse anaphoresis using bioimpedance reflecting what is the sweat production, what is the peripheral resistance. A skin biopsy can be taken to determine what is the nerve density at the intraepidermal level and also to diagnose specific conditions like amyloidosis. Measuring at the blood flow at the microvascular level can also be done by laser Doppler flowmetry after giving a sympathetic stimulus like a mental arithmetic, cold pressure, heating, or using the hand grip tests. Next, eye assessment. So measurement of the pupillary diameter, whether it's a mydriatic or a myotic pupil, doing the direct and the indirect light reflexes, whether it's absent or delayed, and also use of conjunctival administration of 1% hydroxyamphetamine or 4% cocaine can be done. So normally you see a dilatation with both the drugs, but whereas when the postganglionic there's absent or dilatation with both the drugs, and if it's a pre-ganglionic there is response only with hydroxyamphetamine. So in summary, these were the autonomic tests. Strong correlation must be made between the signs and symptoms as well as the autonomic tests. And these tests help diagnosing the coexisting pathology and also to anticipate what are the perioperative hemodynamic changes which we see with the cardiac autonomic tests. So while we anticipate these changes, we can also help formulating a perioperative anesthetic plan like either preloading or co-loading the patient and use of what is the choice of the specific drugs which can be used intraoperatively to maintain the hemodynamic changes. So these factors will be dealt with by Dr. Yatish in the next talk. So I'm sure all the postgraduates are seeing stars, but I must assure you that it is not such a difficult topic. It is like maths where 1 plus 1 is only equal to 2. So once you understand this, I'm sure all of you will become experts in the autonomic nervous system. Thank you so much.
Madam, you are muted. Madam, unmute yourself.
Audible, sir?
Yes.
Yes, sir. So thank you, Dr. Bhargavi. I think she has beautifully justified how an anesthetist working behind the screen safeguards a patient. The ANS is also playing such an important role in maintaining the physiological homeostasis of the patient. And just like any other system, I'm sure you all can understand that the ANS dysfunction in various systemic illness, and it's also implies bedside simple test system wise. So tickle the young brains by throwing a few. Let's wait for it, and after this, let's hear from Dr. Yatish about the anesthetic implications of the dysfunction and how it can be managed. Over to you, Dr. Yatish.
Yatish, you are muted. Unmute yourself.
Yes. Good evening, everyone. With greetings from Bangalore Medical College and thanking Meenakshi Sundaram sir and RHOD SSR and Sandhya ma'am for giving this opportunity to present. I would like to start my presentation.
Yatish, the slide is not moving.
Yeah, just.
Sorry for the small glitch.
Yes.
Yes, Yatish. Yes, it's visible.
Start with the conditions which are associated with the autonomic neuropathy.
Your voice is echoing a bit, Yatish. It's not clear.
So let us start with the conditions associated with autonomic neuropathy. These include diabetes mellitus, multisystem atrophy, postural orthostatic tachycardia syndrome, primary hyperhidrosis, paragangliomas, spinal cord lesions, and alcoholism. Other conditions being been enumerated in the table. So let's go with the diabetic autonomic neuropathy. Why it is important to know about diabetic autonomic neuropathy? Diabetic autonomic neuropathy is important because diabetes is the most common medical condition which we come across in daily clinical practice. With increase in awareness of the health, several patients are getting diagnosed with diabetes, and with long-standing status and poor sugar controls, there is involvement of the autonomic nervous system. With this, more number of patients present to us with elective and emergency surgeries. The incidence of diabetic patients coming for surgeries is about 25%, which is a very large chance. So they present with microangiopathies like retinopathy, nephropathy, and neuropathy, and macroangiopathic changes like atherosclerosis. There is end organ damage, which leads to increase in mobility and mortality, thereby increasing the risk of complications like cardiac dysfunction and infections, and which leads to increased need for surgical interventions. Increased risk of complications needs appropriate perioperative assessment and management, which is very vital to the anesthesiologist. And let us know why nerves are affected more in diabetic autonomic neuropathy or diabetes. All the cells in the body requires insulin to gain entry into the cells. But nerves, retina, and kidney are the exceptions. These are independent of insulin for the intake of glucose. With increased concentration in the glucose levels, which leads to intracellular glucose accumulation and causing nerve damage. Pathophysiology of autonomic disturbance. Impaired glucose regulation affects both somatic and autonomic nervous system, mainly the small fibers. Usually, microangiopathic changes include thickening of capillary basement membrane and hypoplasia of endothelium. And also, there is vasoconstriction, leading to reduced oxygen tension, hypoxia, and thereby causing neuronal ischemia. Hyperglycemia will further lead to activation of different pathways which cause accumulation of sorbitol, increased glycosylated products, and also there is accumulation of diacylglycerol and oxidative stress is increased, which leads to decreased neurotropic factors secretion, and also sodium potassium ATPase action is reduced, and thereby decreasing blood flow to the nerve and causing nerve damage. Also, immunological mediated damage also being suggested. So let us know about presentation of diabetic autonomic neuropathy. Diabetic autonomic neuropathy is amongst the least acknowledged and interpreted complications of diabetes, though it causes severe complications. Clinical symptoms are not evident until long after the onset of diabetes. Subclinical autonomic dysfunctions can be seen just within 1 year of diagnosis of type 2 diabetes or 2 years of type 1 diabetes. Autonomic imbalance may precede the development of inflammatory cascade. Cardiovascular autonomic neuropathy. So nearly around 17% of one diabetics and 22% of type 2 diabetics can present with cardiovascular autonomic neuropathy. This cardiovascular autonomic neuropathy may present a diagnosis and prevalence increases with age, duration of diabetes, obesity, smoking, and poor glycemic control, which acts as very detrimental factors. The usual features, which include abnormal heart rate control, abnormalities in central and peripheral vascular dynamics, and abnormalities in involvement of coronary arteries. Cardiovascular autonomic neuropathy, so which involves one by one. So abnormalities in heart rate control. So due to involvement of the vagus nerve, there is unopposed sympathetic activity which results in resting tachycardia. So reduced heart rate variation is the earliest indicator of cardiovascular autonomic. So later in late stage of diabetic patients, there will be denervation of the heart, which leads to fixed heart rate, which is not responding to any maneuvers. Abnormalities in central and peripheral vascular dynamics. Exercise, there will be impaired exercise tolerance. Normally, when patient exercises or anyone exercises, there is sympathetic and parasympathetic responses will activated, which leads to augmentation of the cardiac output and redirection of the peripheral blood flows to skeletal vessels. But in coronary autonomic neuropathy, this is impaired, which leads to decreased exercise intolerance. Also, there can be various arrhythmias due to autonomic innervation. Also, it presents with orthostatic hypotension, where normally when patient sits from a supine position, there is baroreceptor activation, sympathetic reflex activation, and leads to increase in the peripheral vascular resistance and norepinephrine release along with norepinephrine release. There is increased cardiac acceleration. But in diabetics, this is impaired. So this impaired reflex will cause decrease in the peripheral vascular resistance, putting of blood into lower extremities and causing of orthostatic hypotension. So this presence of exercise intolerance and malignant arrhythmias, orthostatic hypotension can lead to sudden cardiac death. The involvement of coronary arteries is the next one. The incidence is high in diabetics, asymptomatic due to autonomic neuropathy, resulting in delayed recognition and intervention. Any chest pain in diabetic patients should be considered to be a myocardial origin until otherwise it is proven. So, silent myocardial infarction can be a presentation in these patients. So, that we have to consider. Gastrointestinal autonomic neuropathy. So, involvement of esophageal esophageal dysfunction. So, as there is vaginal involvement, which is seen in nearly 40% of cases, there is abnormal peristalsis, and which leads to impaired lower esophageal sphincter tone, which leads to heartburn and dysphagia from cervix. Involvement of gastric autonomic neuropathy, there is delayed gastric emptying and early satiety, so which leads to gastric discomfort and bloating. Also, small bowel can be involved, which can lead to diarrhea, so which may be due to bacterial overgrowth syndrome and characteristically presents as nocturnal diarrhea, and also there can be constipation, which is due to impaired gastric reflex. Also, there is involvement of the system, so which can present as fatal incontinence. So, genitourinary, so there can be neurogenic bladder, so which is characterized by cystopathy. So due to impaired detrusor functioning, there is impaired bladder sensation, leading to incomplete emptying of bladder. There is post-mortem residual urine elevation, so which can increase the frequency and also infections. So any post-mortem residual volume of more than 150 ml can be a diagnostic of neurogenic bladder. Sexual dysfunction can present as erectile dysfunction, retrograde ejaculation, and female sexual dysfunction. So other autonomic neuropathic symptoms can be hypoglycemic unawareness. So that is the continuation of epinephrine release with hypoglycemia. Any hypoglycemia will lead to release of epinephrine, thereby again increasing the glucose level due to reflex activities. But this is blunted in diabetic autonomic neuropathic patients. So, and also it leads to decreased release of plasma pancreatic polypeptides in patients with autonomic neuropathy. So, also discussed the reason with autonomic failure, impaired microvascular blood flow to the skin. So, as there is decreased microvascular insufficiency, there is abnormal contraction of arteries of the skin, which leads to dryness of the skin, and thereby ulcer formation, which causes thickening of infection and gangrene formation. And also there is osteoclastic activity, which leads to decreasing the bone density, so they can be prone for osteomalacias. So also there is these can be dealt with as a doctor's rotary, surface, heating, and hand request. Also, they can present with anemia. So, as there is reduced sympathetic activity or sympathetic stimulation of electropoietic production, so this can lead to anemia. So, all this can lead to increased mortality and major cardiovascular events. So, autonomic assessments. This is already been dealt by Dr. Bhargavi. So, I'll just enumerate these as compared to as presented in the or as tested in the diabetic autonomic. So, this can be cardiac, gastrointestinal, genitourinary, and assessing the cerebral function, assessing peripheral neurovascular responses, assessing pupillary responses. Cardiovascular autonomic neuropathy is that. So tests which are done for cardiovascular autonomic neuropathy. One is heart rate variation with deep breathing. So and that is been explained. The patient will lay down and he breathes with a heart rate of around 6 to 7 per minute, and will record for variation, that is maximum and minimum heart rate. So, and we'll see what is the variation. So, usually there is normal variation, normal patient variation is seen, but in diabetics there is no much variation. And heart rate response to standing. So, again, maximum and minimum there is 30 up to 50 taken. So, which is this is usually increases in heart rate followed by decrease in heart rate. But in diabetics, there is increase in heart rate is gradual. And also response to glycemic maneuver and BP change has to be done. And BP changes with standing. That is, any fall or any pressures more than 30 mmHg or diastolic blood pressure of more than 10 mmHg is taken. And also pancreatic dynamics can be there is changes in blood pressure for pancreatic can be over spectrometric analysis has to be done. So gastrointestinal autonomic neuropathy. So that is gastrointestinal assessment. It's done by assessing glycemic control and taking history regarding the medications like anticholinergics or psychotropic drugs, and gastroduodenoscopy, manometry, double isotope scintigraphy, and double isotope scintigraphy and electrogastrography. Test for diagnosis and assessment of constipation. Colorectal manometry for evaluating sphincter tone and rectal anal inhibitory reflex. Then colonic segmental transit, pelvic examination has to be done. And for evaluating the diarrhea, so the presence of ova and parasite has to be ruled out, and other causes for diarrhea has to be ruled out. Assessing genitourinary autonomic functions, erectile dysfunction, so take a detailed history of medical history, sexual function history, glycemic control, hormonal and psychological evaluation, and specific tests like nocturnal penetrance, renal brachial pressure index, sacral outflow assessment, and injection of vasoactive compound, which can cause a response of 65 to 70%. So predominantly there is neurogenic, and if the response is less, or there is the failure of response, that device or it determines it is a venous incompetence. So the other assessments being bladder dysfunction, assessing pseudomotor functions, assessing peripheral neurovascular responses, and assessing pupillary functions. So SAN Antonio consensus panel recommendations are these SAN Antonio consensus panel gives the recommendations which are recommended to classify any diabetic as a diabetic autonomic neuropathy. So these are the symptoms possibly reflecting autonomic neuropathy should not by themselves be considered markers for its presence. Non-invasive validated measures of autonomic neuropathy. So that should be considered if and after ruling out any end organ failure, and also any concomitant illness or drug use is there, and also considering age into consideration. An abnormality on more than one test or more than one occasion. So more than one abnormality, more than one test on more than one occasion is desirable to establish the presence of autonomic dysfunction. Yeah, and also we have to do independent tests of both parasympathetic and sympathetic functions. And quantity of quantitative measures of autonomic reflexes should be used to monitor improvement or deterioration of autonomic functions. So, what are the preventive implications of cardiac autonomic neuropathy? So, it helps in tight control of glycemic control, and it facilitates decision to treatment has to be initiated, and also it emphasizes the importance of adherence to diet and exercise interventions. So, now we come to the anesthetic implications of this autonomic neuropathy. So, usually, regional anesthesia will be a safer one. So, it can be considered as choice of anesthesia, as there will be pain relief and also blend of surgical stress response. But we have to consider the deleterious effect, that is hypotension, which is present with regional anesthesia. But these same effects may be seen in general anesthesia also. So, the best choice of anesthesia has to be determined based on the patient's clinical presentation and doing a pre-anesthetic evaluation. Gastric emptying time is delayed in these patients, which so we have to consider a strict guidelines for NPO status and use of metoclopramide to decrease gastric emptying time. So metoclopramide is administered in these patients, and also these patients are more prone to aspiration, so that we have to consider. And if anemia is present, it need to be directed. Diabetic patients with autonomic neuropathy may present either with exaggerated or attenuated mechanisms. So, careful monitoring with titrated anesthetic regimen and use of titrated drugs and minimal airway manipulation and intervention is required to maintain cerebral hemodynamics. There can be an exaggerated or attenuated response, hemodynamic response for laryngoscopy. Perioperative cardiovascular liabilities will be more in this patient. So, severe hypotension, which will not be responding to inotropes, can be present, and we have to assess for volume status of this patient and titrate dose of anesthetics and monitoring like arterial blood pressure, ECG, and central venous pressure has to be done. So these patients are prone to hypothermia. So decreased blood metabolism and impaired healing will be present. So continuous temperature monitoring, and also methods to maintain the temperature has to be taken. There will be impaired hypoxic induced ventilated response. So drug dosage has to be titrated, and judicious use of opiates should be considered. Uncontrolled cardiovascular stability, especially with central axil anesthesia. So often spinal cord failure can be blood pressure. So preoperatively, we have to assess the patient, and fluid has to be preloading or counterloading should be considered. And nerve blocks, preferably ultrasound guided, are safe in this patient for pain management. The presence of peripheral neuropathy must be well documented in this patient preoperatively. So risk of infections are more, so that it can lead to epidural abscess formation within the neuron. Then risk of neuropathy after peripheral nerve blocks can't be ruled out. So strict vigilance, monitoring, and controlled blood sugars are essential depending upon time and duration of the surgery throughout the preoperative procedure. Also, we should consider slow positioning of the patient. So, any sudden change in the position can cause exaggerated hypotension or bradycardia. So, this can be prevented by slow positioning of the patient. I will also, these patients should be required padding of vulnerable areas. So, like calcium can be any other compressions can present. So, you have to provide adequate padding of these parts. Then, orthostatic hypotension may precipitate in post-operative period also. So, continuous monitoring post-operative supplementation is also required. The post-operative paralytic areas. So, usually after complete surgeries can present. So, strict control of blood sugars can decrease these problems. Then, adequate post-operative pain management, particularly ultrasound guided nerve blocks, can be used. These diabetic patients, when they come for emergency surgeries, they should always consider diabetic ketoacidosis, which can be present. So, in that case, patient has to be sterilized before taking for surgery. Gold standard tests for cardiovascular autonomic nervous system, such as heart rate response to the deep breathing, standing, and vascular maneuver, and blood pressure response to standing are considered as a gold standard in clinical testing of autonomic. Their applicability in bedside clinical practice is based on the sensitivity, specificity, and reproducibility and safety of user standardization. So, summarizing diabetic autonomic neuropathy. So, diabetic autonomic neuropathy, along with other pathophysiological diseases, is a known thing. Many operative management of patients undergoing surgery. So, patients with autonomic neuropathy should be properly assessed with battery of tests, optimized and with timely interventions for safe outcome. So, after this, we go to other causes of weight loss autonomic neuropathy. So, among them, one is multiple system. Here, the decompression of and dysfunction of brains, certain nervous system structures. So, like strato-negative fibers, oligopontine cerebellar atrophy, and Shagg syndrome. So, which can present with symptoms of Parkinsonian features, cerebellar dysfunction, so they present with the symptoms of orthostatic hypertension, syncope, urinary retention, sluggish pupillary reflexes, and sexual dysfunction. This can be treated with elastic stockings, consumption of high sodium diet to expand plasma volume, and administration of vasoconstricting alpha-1 adrenergic agonist or alpha-2. So, for management of anesthesia in this patient, so continuous monitoring of systemic blood pressure has to be done, fluids and vasopressors as required, and spinal or vertebral can be considered, although the risk of hypertension demands vigilance and caution. And intravenous ketamine has less hypertension, and signs of light anesthesia may be less appreciated in these patients. So, that has to be considered. And anti-Parkinson's medications, if they are taking, that has to be continued. Postural orthostatic bradycardia syndrome. So episodic and position-related hypertension is a presentation. So it is present in young women's normally. And the symptoms being palpitations, and also lightheadedness, fatigue, and syndrome. So this is treated with increased intravascular fluid volume and alpha-1 adrenergic agonist such as amlodipine. So management of anesthesia preoperatively needs to expand intravascular volume, low dose infusion, and SFR hypersensitivity as it's present. So if beta adrenergic blocking drugs may be used. So in these cases. It can also be present in paragangliomas. So paragangliomas, which are pleural tumors, from breast cells. So they can be non-saturating or saturating. So when they are saturating, they can saturate non-epinephrine, that is phlebotomocytoma, and cholecystectomy. Then the paralytic kinase will be present and central kinase will possibility is 20%. And histological so these can be treated, this paragangliomas can be treated either with radiation or embolization or surgery. So anesthetic management. So we have to assess for the critical metabolites and CO5 hydroxy indoor acid. So and preoperative we may have to start benzoxamine or prozosine pyrrolide and invasive monitoring is required. Antihypertensive treatments may be used intraoperatively. So that has to be taken. And post-operatively, preoperatively or post-operatively, there can be cranial deficits like vagus nerve suspension and hypertension. We do research into then it can present with unilateral mobile or palsy. Embolization is done there. So venous embolism can be complication. Carotid sinus hypersensitivity, exaggerated activity of balance central. So cardio-inhibitory coefficients leads to profound bradycardia and impaired vasodepressor hypotension. So this can be treated with medications, cardiac pacemaker, or patient status. So management of anesthesia. So it is invasive monitors like and drugs to treat hypertension and external cardiac pacemaker. In next is hyperhidrosis. So where there is excessive amount of sweating, which can be identified secondary. So when it is secondary, it can be due to hyperthyroidism, phlebotomocytoma, hypothalamic disorders, spinal cord injury, Parkinsonism. Then overactivity of cerebromotor nerve fibers in sweat glands. This can be treated with antiperspirants, anticholinergics, and surgical symptomatology. When the patient comes for surgical symptomatology, so usually video assistant thoracoscopy and required. So manual ventilation will be required. There can be unilateral or ipsilateral upper extremity vasodilation in ipsilateral upper extremity. The common surgical complications include infection, Arnold syndrome, compensatory hyperhidrosis, and spread distant arthritis. Familial dysautonomia. So it's also called biliary syndrome. So it's a hereditary cause. Autosomal recessive hereditary. It can present at birth with features of food surgery, hypotonia, and failure to respond to patient's feedback. Later, vomiting or recurrent aspiration pneumonia and failure to drive steady gait or scoliosis related aspect. So this autonomic crisis here, the response to stress, there is hemodynamic liability and excessive diaphoresis, tachycardia or bradycardia can be treated. There is no treatment for this familial dysautonomia. So there is increased morbidity and mortality in these patients. So there is 50%, so 50% survival probability of reaching to 40 years of age. Management of anesthesia in these patients. So preoperatively, we can use anxiolytics, and as they are dehydrated, so relieving aspirin and insulin therapy up to 50%. And using microcorticoids can reduce or also intraoperatively, we should use rapid sequence inhibition and arterial antihistamine. And so sensitive, they are very sensitive to use of vasopressin. So they are maintenance of monotherapy has to be done. So due to the involvement of lateral movements, corneal compressions, so side care has to be done. Post-operatively, hypotonia aspiration and there can be profound post-operative non-loss. Then oxygen dependency can be very.
Thank you, Dr. Yatish, for that detailed description of how systemic illness can affect the autonomic nervous system, the implications on the intraoperative physiology of the patient, and how it can be managed. Touching upon a very important topic of diabetes, because it's slowly evolving as one of the most prevalent NCD, especially in our country. And with more and more diabetic patients presenting to us for surgery, I think it's very important that the postgraduates are oriented, that they use these tests which were described by Dr. Bhargavi preoperatively, so that, as I already highlighted, it's for patient safety finally. Sir, do you want to add few points before we take on the questions?
Yeah, you please take on the questions. It is not
Yes, sir.
me adding it.
Yes, sir. Dr. Bhargavi, can you please answer this question in the chat box? There's a question about the ratio of alpha and beta in labetalol and how it's important for the anesthetist.
The ratio of alpha to beta blockade on oral administration is 3:1. It has a predominant beta action. And with alpha, IV administration, it's in the ratio of 7:1. That is, it has a more potent beta action as compared to the alpha action. So primary action will be the beta 1 blockade action, that is fall in the heart rate and cardiac output, and it's a more beta specific action. So it can be used to control the heart rate to any intraoperative stress responses like laryngoscopy. It's especially used in pregnant patients, in PIH patients, and also in other hypertensive crisis management, like in case of hyperthyroidism and in case of pheochromocytomas, where both alpha and beta blockade action is preferred. So that is the use of labetalol and the specific of its action.
Madam, one more I think I want to say, because he has
in any catecholamine search.
No, he has asked about alpha and beta ratio. So he should be answered 1:3 instead of saying 3:1.
1:3. Yes. 1:3 and 1:7.
Usually we used to
1:3
say
and
beta
1:7.
alpha, but he has asked about alpha beta.
Correct.
So it
Correct.
has mathematically
Yes,
it should be changed.
Yes.
If there are no other questions, I think Dr. Bhargavi, madam, you can give the answers for the postgraduate, or you have to give the choice to the moderator or the academic chairman of Puthukkottai Bhudhan. That is your if you please open and elaborate on that.
Yes,
sir, the first question regarding what is the better vehicle for catecholamines, it is 5% glucose, because we require an acidic medium mainly for to avoid the precipitation and breakdown of the catecholamines. So an acidic medium is preferred, so 5% glucose is a better choice. And coming to the next question, in propranolol overdosage, the specific antidote would be glucagon, because it directly acts by releasing cyclic AMP. It doesn't act through the release of norepinephrine and receptors level, which may already be blocked. So the specific antidote is glucagon, but also supportive treatment can be given with atropine. And also calcium and other supportive drugs can also be given, but the specific antidote will be glucagon. And the third test is Ewing and Clark, where the pioneers in expressing these autonomic tests, they have described these as early as 1980s, and they have been even used even today, especially for they have described it primarily for diabetic autonomic neuropathy, and they hold good even today. And as we have already seen in diabetic neuropathy, these tests are very important to have an idea of the hemodynamic changes which occur intraoperatively. So I think those are the answers to the three questions that I had mentioned, sir.
Madam, with the permission of the moderator,
Yes, sir.
I want to answer your three questions.
Yes, sir. Please.
First, I request you please verify, because I have read it a long time back. Probably you are still in the teaching profession, but the ideal vehicle for all the ionotropes. What I meant to say, if you don't know anything, you can immediately say normal saline. For two reasons. One, see, normal saline will not produce hyperglycemia. Usually, for all the patients who are suffering from myocardial shock, they may be diabetic. So, definitely 5% dextrose. Another problem is 5% dextrose precipitate the drug. So, if I am right, isoproterenol, that is isoprenaline, you have mentioned it as isoproterenol, that is the only drug which requires 5% dextrose, because it is neutralized by the alkaline media. So I should be stand corrected. Please check, because it is exactly the opposite we are telling. So the ideal vehicle will be normal saline. You can check. If I am wrong, I should be stand corrected. Then your glucagon, as you say, glucagon, even see, you have to elaborate those answers so that the PGs will be benefited, because even you can go for high dose insulin with dextrose. For this propranolol, you can give soda bicarb. Then at some time they may even require ECMO. But for anything, if the patient is in arrest, that ABC routine airway breathing circulation is to be maintained. And as you say, this Ewings, he has published his papers in 1875, 1985. 1985, he has published it about this autonomic hyperreflexia. So that is right. And I think another question has come before our discussion. Madam Sandhya, madam, it is yours.
Yes, sir. Yes, sir. Yes, sir. What are the fetal effects of labetalol? Dr. Bhargavi.
I'm not
Yes.
sure about this, ma'am, because it's actually been used in pregnant patients also. So I wouldn't know if there are any.
It is very easy to answer that question. See, in any case, in pregnant patients, we are not going to maintain a esmolol infusion. See, usually to blunt the response of this laryngoscopy and intubation, we may be using that, but it is going to be a single dose, which is going to be short-lived. So there is no question of this labetalol crossing this thing. It is just like esmolol. Patients on PAH, they are routinely taking this labetalol, even 100 milligram 3 times daily, even 100 milligram 6 times. I have seen patients. So esmolol and this labetalol cannot produce any toxic effects on the fetus, because we are seeing they are taking months together. Labetalol is given nowadays, the first therapy they are using it as labetalol only. So when plenty of labetalol is taking, it's not going to produce any deleterious effects on the fetus.
Yes, sir.
Yeah, he has mentioned that he has mentioned all catecholamines are.
Elements.
That's what. So that will be
Like.
neutralized. Yeah, that is a problem.
Yes, sir. Mainly what you said for this one is true, sir. That what we routinely get is normal saline, that will be preferred. Especially, we should avoid infusion simultaneously with soda bicarb, which maintains the
Yes,
alkaline.
that is alkaline, because that is the reason why he has mentioned,
Yes,
Dr.
sir.
Bhargavi has mentioned. See,
Yes, sir.
that is a discussion. See, without even today, after this, I will check the vehicle for inotrops. That is how we improve our knowledge.
Yes,
It is
sir. Yes,
from
sir.
my practical view, I am saying probably that is the advantage of continuing medical education and listening to the present day teachers, but we should not give a wrong message. At least when there are conflict of opinion, the postgraduates will check in their book what is the right media. That is how we inoculate knowledge. It is not right or wrong, it is verification.
Yes, sir. It's a stimulus for the postgraduate.
Yes. What you have done is right. Another one, the questions may be less because we are talking about basics. Anatomy
Yes,
and physiology, they cannot ask a doubt in that. What is a sympathetic outflow? What is that is the only one point.
yes, sir. These are all the basic concepts, sir. But basically, we should avoid an alkaline medium, coincidental administration of soda bicarb. All those things must be avoided. Maybe
That is the
glucose.
reason why he has given that all categories are acidic in nature. He wanted to mention. But anyway, what I am saying, the glucose load we have to avoid.
Yes,
It is
sir.
not
Yes.
simple thing. The glucose load which you are giving, because normal saline is going to be acidic. But the thing is, it is normal saline. That is the reason why we call it as normal.
It's normal.
It is
Normal.
isotonic. Yeah.
Yes.
But actually it is abnormal saline. Actually it is abnormal saline, but just because it is isotonic, the nomenclature has become normal saline.
I don't think.
If there are no more questions,
No
madam,
more
can
questions, sir.
give the
No more.
concluding remarks, madam.
Yes, sir. I think we thank Dr. Shashank, Dr. Bhargavi, and Dr. Yatish for taking us through the continuum of the anatomy, physiology, the pharmacology, and what are the implications of a dysautonomic system and how to test it and how to manage it intra and post-operatively. And we also thank you, sir, for giving us the opportunity for this institute and keeping trust in us that we will do our job satisfactorily, and hopefully we have done it. And postgraduates have got an insight about the importance of the autonomic nervous system, sir. Thank you so much.
Thank you, madam. So, on behalf of our Puthukkottai branch of ISA, I want to thank Dr. Shashank, Dr. Bhargavi Sanket, Dr. Yatish, and moderator Professor Dr. Sandhya for the wonderful explanation. As moderator has pointed out, they have thrown light on anatomy as well as physiology, pharmacology, then applied physiology and applied pharmacology. So it is such a great, and everyone has complemented without touching, overlapping on each other. They have continued successfully. So that means they have done their homework. That is an advantage if they are coming from a single institute. And I again thank Bangalore Medical College for the largest contribution in this Puthukkottai Bhudhan second edition. And tomorrow I'll be calling every one of you over phone, and we will get the number of attendees by tomorrow from the back-end team. And I request Clearnet to pass their concluding remarks and to close the session.
Yes, sir. Thank you, sir. Thank you so much, everyone, for giving us the opportunity to host the session today. So, with this, we are concluding the session over here. Thank you so much.
Thank you.
Thank you, sir. Good night.
Thank you. Thank you, sir.
Thank you.